Peter Block here in Orlando at the AHA annual meeting for On the Scene, and with me is Bob Yeh from the Deaconess and Beth Israel in Boston. The dual antiplatelet study, Bob, you've been involved with for a while, and you looked now at a new sort of look at this in terms of scoring patients for risk versus benefit. I'm not even going to try to figure out exactly what you did. I'm going to have you tell me. So in the short version, what did you do looking back at the DAPT data?
Sure. The main results of DAPT showed that extension of dual antiplatelet therapy decreased ischemia but increased bleeding. What we wanted to do is identify the individual patients who might derive greater or lesser benefit from dual antiplatelet therapy, and we did that by building a model or a risk score called the DAPT score, which could identify those patients who had the most to gain as well as the most to lose from dual antiplatelet therapy.
Okay, so the score is based on two factors, right? Their risk of ischemia and their risk of bleeding.
That's right. So we first constructed two different prediction models, first to predict bleeding and then to predict ischemia, and then integrated those two predictions into basically what culminated into this integer risk score to define the patients that had the most to benefit.
So what's good, a high or low score, and how did that score work out?
It's a score that ranges from -2 to 9, with a higher score reflecting a greater predicted benefit rather than harm, and a lower score predicting overall greater effect on bleeding or more harm. It turns out that a score cutoff of 2 or more defines a population with a much greater expected benefit from continuation of therapy, whereas patients with less than 2 were more likely to be harmed.
Okay, and when I was looking at these data, Bob, it looks to me like the risk benefit is always there. There's always some risk associated with it, even though your DAPT score may be high. Would you agree with that? But nevertheless, the benefit outweighs the risk. Is that a fair assessment of this?
I would say that the risk in the high DAPT score group is much less. So for example, for a high DAPT score patient, you are about 8 or 9 times more likely to prevent a stent thrombosis or an MI with continued therapy than you are to cause a bleed. Conversely, with the low DAPT score patients, you're 2.5 times more likely to cause a bleed than prevent an ischemic event.
Okay, so test me on this, Bob. I'm going to make a clinical pearl here out of all this. So for all the clinicians out there, if you can identify a patient that has a high DAPT score, you in fact will have a greater benefit for continuing dual antiplatelet therapy than risk. And the reverse, of course, low DAPT score, maybe you ought not to continue. Fair enough?
Yeah, I think that's really our takeaway. We don't expect clinicians to be able to do this all in their head with calculating a DAPT score, so we are making a web-based calculator available at the time of the presentation of the paper.
Thank you, Bob.